Let me ask you something, and I want you to be honest with yourself. Have you ever finished an intimate moment feeling like something was missing? Like you were there, you were present, you were trying, and yet that peak, that release, that moment of true pleasure that you either rarely reach or maybe have never reached at all, it just didn't happen. You're not broken, you're not unusual, and you are absolutely not alone. Statistics from the Journal of Sexual Medicine tell us that only about 18% of women can reach orgasm through penetration alone. 18%. That means more than 80% of women, the vast majority, need something more, something different, something their bodies are actually designed for, that nobody ever properly explained to them. And here's what frustrates me as a doctor. This is not new information. The research has been there for decades, but somewhere between the medical journals and the bedroom, this knowledge just disappears. It never reaches the people who need it most. So today, that changes. I'm going to walk you through the 4 best sexual positions for female orgasm, not based on magazine polls, not based on what looks good in movies, but based on peer-reviewed science, urological research, and real clinical understanding of female anatomy. Stay with me through this entire video, because the 4th position I'm going to share with you is the one that surprises almost everyone, and it might be the most powerful shift you can make starting tonight. Hello, and welcome back to the channel. I'm Dr. Lila Romano, intimacy counselor, marriage therapist, and sexual health specialist. I've spent over 15 years working with couples and individuals in clinical settings, helping them navigate everything from communication breakdowns in the bedroom to complex sexual health concerns that affect both physical and emotional well-being. If you're new here, welcome. This is a safe, judgment-free space. I talk about the topics that most doctors rush past in a 10-minute appointment, or that you're too embarrassed to Google because you're afraid of what comes up. I give you the real, science-backed information you deserve, delivered with the respect and clarity that every adult deserves. If you've been here before, welcome back, and thank you for trusting me with your time and your well-being. On this channel, I believe one thing deeply: an informed woman is an empowered woman. And empowered women have better relationships, better health outcomes, and yes, better sex lives. So let's get into it. Before I give you the 4 positions, I need to spend a few minutes giving you the why behind all of this. Because when you understand your own anatomy, when you understand what your body actually needs and why it needs it, everything else clicks into place. The positions stop being tips and start being tools you actually know how to use. Let's start with the science. Okay, let's talk anatomy. And I promise I'm going to make this the most interesting anatomy lesson you've ever had. The female orgasm is, at its core, a neurological and vascular event. What that means is, it involves your nervous system firing a very specific sequence of signals, combined with increased blood flow to the pelvic region. When that combination reaches a certain threshold, that's the orgasm. Now, there are a few key anatomical players in this process, and understanding each one is going to make everything I say later make complete sense. The clitoris, the most misunderstood structure in the human body. Let's start here, because most people, including many doctors, have a fundamentally incomplete picture of what the clitoris actually is. Most people think of the clitoris as a small external nub. And yes, that external glans is part of it. But here's what the research, particularly the landmark work done by Australian urologist Dr. Helen O'Connell in the 1990s and early 2000s, revealed. The clitoris is actually a large, wishbone-shaped internal structure. The full clitoral complex includes the external glans, what you can see and touch, the clitoral shaft, which runs internally upward, 2 crura, long arms that extend backward along the pelvic bone, 2 vestibular bulbs, internal structures that run along either side of the vaginal canal. When fully aroused, the entire clitoral complex engorges with blood, similar to how a penis becomes erect. The whole structure swells, becomes more sensitive, and essentially wraps around the vaginal canal. This is crucial, because it means that internal stimulation, the right kind, in the right location, at the right angle, can stimulate the internal portions of the clitoris even without direct external contact. That's the foundation of why certain positions work better than others. The G-spot, real but misnamed. Now let's talk about the G-spot. This is a topic that has caused enormous controversy in sexual medicine. Some researchers have argued it doesn't exist, others swear by it. Let me tell you where the current science actually lands. The area commonly called the G-spot, located on the anterior wall of the vagina, roughly 2 to 3 inches inside, is not a distinct anatomical structure the way a bone or organ is. What it actually is, according to the most current research, is the vaginal surface of the internal clitoral clitoral complex. In other words, when you stimulate the G-spot, you are stimulating the internal roots of the clitoris through the vaginal wall. This is why the G-spot debate has been so confusing. People were arguing about whether a structure existed, when really they were talking about two different ways of accessing the same network. This also explains something that has puzzled many women: why G-spot stimulation combined with external clitoral stimulation feels so dramatically more intense. You're engaging the same clitoral network from two directions simultaneously. The role of arousal: why just starting doesn't work. Here's something I want every woman watching this to internalize. Your anatomy literally changes during arousal. When you are adequately aroused, not just physically stimulated, but mentally and emotionally engaged, the following happens. The vaginal canal elongates by up to 2 centimeters. The cervix and uterus lift upward in a process called tenting. The vaginal walls produce lubrication. And critically, the entire clitoral complex engorges and descends slightly, bringing the internal structures closer to the vaginal walls. What this means in practice: the positions I'm about to describe work significantly better when you are fully aroused first. If you skip adequate foreplay and arousal, you're essentially trying to access anatomical structures that haven't fully activated yet. I cannot emphasize this enough. Arousal is not optional. It is physiologically necessary for these positions to deliver what they're capable of delivering. The orgasm gap: why this information matters. Before we get into the positions, I want to name something clearly. Research published in the Archives of Sexual Behavior, the largest study of its kind, found that 95% of heterosexual men reported usually or always reaching orgasm during sex. For heterosexual women, that number was 65%, and for women with female partners, it was 86%. That gap, the orgasm gap, is not about anatomy. Women's bodies are fully capable of consistent, reliable, powerful orgasms. The gap exists because of a lack of information, a lack of communication, and a cultural overemphasis on penetration as the primary or only sexual act that counts. Every position I'm going to share with you today is specifically chosen to close that gap, to work with female anatomy rather than around it. All right, let's get into the positions. The first position might surprise you, because I'm starting with missionary. Yes, missionary, the position that has an undeserved reputation for being boring, basic, or ineffective for women. But here's the thing: standard missionary, done the standard way, is indeed not optimal for female orgasm. The research backs that up. In standard missionary, the penis typically moves in and out, providing primarily vaginal wall pressure, which, for most women, isn't sufficient for orgasm. But modified missionary, specifically using a technique called the Coital alignment technique, or CAT, is a different story entirely. What is the CAT method? The Coital alignment technique was developed and studied by sex researcher Edward Eichel in the 1980s and published in the Journal of Sex and Marital Therapy. A follow-up study in the 1990s showed that women using the CAT method reported significantly higher rates of orgasm during intercourse compared to standard positions. So what is it? In standard missionary, the penetrating partner positions their body directly above, with movement being primarily in and out. In the CAT position, the penetrating partner shifts their body upward by approximately 2 to 4 inches. Their pelvis is now higher than usual, creating a different angle of penetration. The result of this shift? Instead of in and out thrusting, the movement becomes a rocking, grinding motion where the base of the penetrating partner's pelvis creates continuous friction against the external clitoris with every movement. Think of it as switching from a hammering motion to a rocking chair motion. The bodies stay connected. The movement is rhythmic and sustained, rather than withdrawing and re-entering. Why this works? The anatomy. Remember what we talked about with the clitoral complex? That external glans, the visible clitoris, is the most densely nerve-packed structure in the entire human body. It has approximately 8,000 nerve endings in a structure smaller than your fingertip. By comparison, the entire penis has about 4,000. That structure needs direct, sustained friction to generate the neurological cascade that leads to orgasm. In the CAT position, the upward shift of the partner's body means that every single movement creates pressure and friction directly against the external clitoral glands. You are no longer relying solely on internal stimulation to maybe reach the internal clitoral roots. You are directly engaging the most sensitive structure in your body with every movement. Here's exactly how to do the CAT position. Step 1. Begin in standard missionary position. Step 2. The penetrating partner shifts their entire body upward, moving their chest higher so their pelvis is elevated relative to their usual position. Their weight should be supported on their forearms. Step 3. Instead of thrusting in and out, the movement becomes a forward and backward rock. On the forward rock, the base of the partner's pelvis presses against the clitoris. On the backward rock, gentle withdrawal, keeping the bodies connected. Step 4. Find a slow, sustained rhythm. This is not a fast technique. The research shows that slow, deliberate pressure is far more effective than speed. For the receiving partner, you can enhance this significantly by placing a firm pillow or a specialty wedge pillow under your hips, tilting your pelvis slightly upward. This brings the clitoris into even closer contact with your partner's pelvis. It also adjusts the angle so that internally, the penis is pressing more directly against the anterior vaginal wall, the G-spot region, simultaneously. Tip from the clinic. The first time you try this, it will feel different, possibly less intense in the traditional sense because the hammering motion is gone. Give it time. Women who learn this technique consistently report that once they adjust to it, they find it significantly more reliably orgasmic. The slow build is the whole point. I want to pause here and say something important. Every technique I share today requires communication with your partner, not a long, awkward conversation, just simple, clear guidance. I want to try something. Can you shift up a little? Now rock. Don't thrust. Your partner wants you to experience pleasure. They want to know what works. Give them that gift. Be their guide. It makes the experience better for both of you. Position number 2 is woman on top, and this one I want to talk about carefully because most women are doing this position in a way that is significantly less effective than it could be. First, why is this position on the list at all? A 2011 study published in the journal Hormones and Behavior and additional research compiled in the Female Sexual Function Index found that woman on top is one of the positions most strongly associated with female orgasm. The reason is simple: control. When you are on top, you control the angle of penetration, the depth of penetration, the speed and rhythm of movement, and critically, the type of movement. That last point is where most women leave enormous pleasure on the table. Here's what most women do when they're on top. They bounce, up and down, in and out. It looks like what they've seen in movies. It's a perfectly natural instinct, and it is, for most women, not the most orgasm-effective movement. Why? Because it's primarily providing internal stimulation, vaginal wall pressure, and depth, without creating the friction against the clitoris that the majority of women need to reach orgasm. The research-backed modification is this. Instead of bouncing up and down, tilt your pelvis slightly forward and grind. Here's how to think about it. When you're on top and you lean slightly forward, shifting your weight toward your partner's chest rather than sitting straight upright, your clitoris moves into direct contact with your partner's pubic bone or the base of their body. Now, instead of moving up and down, you move forward and backward, like a rocking motion. Your hips roll forward and back rather than lifting up and down. Every forward grind creates direct pressure and friction against your clitoris. You are in complete control of the pressure, the speed, and the angle. This is something I spend time on with clients in therapy because every woman's anatomy is slightly different. The angle that perfectly aligns your clitoris with your partner's body is unique to you, and you will only find it by experimenting with lean. Try leaning forward slightly, more forward, then back. Notice when the sensation becomes most intense. That's your angle. Remember it. That's your starting point every time you're in this position. Clinical tip. Using a small vibrating device, a clitoral vibrator, while in the woman on top position is one of the highest success strategies I recommend in therapy. You are providing both internal stimulation and external clitoral stimulation simultaneously, engaging the full clitoral complex from both sides. Studies show that adding a vibrator to intercourse increases the likelihood of female orgasm from approximately 18% to over 70%. There is absolutely nothing wrong with this. It is a tool. Just as you might use a pillow to adjust an angle, you use additional stimulation to meet your body's actual needs. The psychological dimension. I also want to name something about this position that goes beyond mechanics. Woman on top is psychologically empowering for many women. You are not passive. You are not waiting. You are actively driving your own experience. You are listening to your own body, following your own sensations, directing your own pleasure. For women who struggle with getting out of their head during sex, which is one of the most common barriers to orgasm, this position can help. When you are in control of the movement, your brain has a clear task. It's harder to drift into worrying about how you look, or whether it's taking too long, or any of the other mental spirals that kill orgasm before it starts. You are the driver. Stay in your body, follow the sensation. Position 3 is rear entry, commonly called doggy style. And I want to talk about this one with the same clinical precision we've applied to the others, because the reason it works is genuinely fascinating anatomy. Why rear entry uniquely accesses the anterior wall. Remember the anterior vaginal wall? The G-spot region, the internal surface of the clitoral complex? In most standard positions, the angle of penetration directs pressure toward the posterior, back, wall of the vagina. This is simply the physics of most sexual positions. Rear entry is different. Because the penetrating partner is approaching from behind and typically below, and the natural curve of an erect penis, or the angle of a toy, faces upward in this position, the anterior wall receives direct, consistent pressure with every movement. A 2010 paper in the International Journal of Impotence Research specifically identified rear entry as one of the positions most anatomically suited to anterior wall G-spot stimulation, noting that the angle of approach in this position consistently engages the anterior vaginal wall to a degree not achievable in most face-to-face positions. The variations that matter. Here is something important. Rear entry is not one position. It is a family of positions, and small modifications create dramatically different experiences. Variation 1. Standard all fours. Both partners kneeling, the receiving partner on hands and knees. This is the baseline. Effective but can be improved. Variation 2. Chest down/hips elevated. The receiving partner moves from hands and knees to resting their chest on the bed or pillow, with their hips remaining elevated. This is sometimes called the flat doggy or prone variant. This position does two things. It increases the angle so penetration more directly targets the anterior wall, and it also allows the receiving partner to tighten the pelvic floor muscles more easily, which we'll talk about in a moment. Variation 3. Pillow under hips. Lying face down with a firm pillow under the hips, elevating the pelvis. In this variation, the receiving partner has their legs together, which naturally narrows the vaginal canal and increases sensation intensity. The anterior wall pressure in this configuration is significantly increased compared to standard positioning. Here's the clinical reality I share with my patients. Rear entry, while excellent for anterior wall stimulation, typically lacks direct clitoral contact. The bodies are not aligned in a way that creates external clitoral friction during penetration. This means that to achieve orgasm in this position, you have two options. Option A. The receiving partner uses their own hand or a small vibrator to provide external clitoral stimulation simultaneously. In the chest-down variation, this is particularly easy. You simply reach underneath yourself. Option B. The penetrating partner reaches around the receiving partner's body to provide manual clitoral stimulation during the act. Either option transforms this position from good internal stimulation to full clitoral complex engagement, which, as we've established, is what the majority of women need for orgasm. I want to take a moment here to talk about something that doesn't get enough attention in conversations about sexual positioning: the pelvic floor. Your pelvic floor is a hammock of muscles that sits at the base of your pelvis, supporting your bladder, uterus, and rectum. These muscles also play a direct role in orgasm. The rhythmic contractions that you feel during orgasm are, in fact, these muscles contracting involuntarily at approximately 0.8-second intervals. Here's what the research shows. Women with stronger, better controlled pelvic floor muscles report more frequent, more intense orgasms. And certain positions allow you to consciously engage these muscles during sex in ways that can dramatically intensify sensation. In the rear entry chest down variation, you can practice consciously squeezing and releasing your pelvic floor muscles in rhythm with movement. This is essentially Kegel exercises during sex, and women who do this consistently report it as a significant intensifier of both the approach to orgasm and the orgasm itself. If you've never done pelvic floor exercises, I strongly encourage you to start. They take 5 minutes a day. The benefits, not just for sexual pleasure, but for urinary health, pelvic organ prolapse prevention, and postpartum recovery, are well documented and significant. And here we are. Position 4, the one I told you at the beginning would surprise you. I want you to set aside everything you think you know about what exciting sex looks like. Because this position, the lateral scissors position, also called side lying or the scissors, is possibly the most underrated, most overlooked, most anatomically intelligent position for female orgasm, and almost nobody talks about it. In this position, both partners lie on their sides, facing each other, or one partner behind the other. The bodies are intertwined so that penetration occurs from the side, with the legs of both partners creating a scissoring configuration. There is minimal thrusting. Movement is gentle, close, and rocking. The bodies maintain constant full contact. Sounds simple, almost too simple, and yet, here's what the science says. Reason 1, sustained clitoral contact. Because the bodies are pressed together in full-length contact, with the pelvises aligned, there is sustained, consistent pressure against the external clitoris throughout. This is similar to the CAT mechanism, but in this position, it happens naturally from the side-lying configuration. There is no specific technique required. The anatomy of the position does the work. Reason 2, reduced performance pressure. Here is something that the literature on female sexual dysfunction consistently identifies as one of the top barriers to orgasm: performance anxiety and self-consciousness. The lateral position is the most psychologically relaxed of all 4 positions we've discussed today. The bodies are horizontal, equal, not on display. You are face-to-face or nestled together with your eyes possibly closed. There is no performance happening. There is simply 2 bodies in close contact, moving gently together. For women who struggle to let go, who find themselves monitoring their own responses, wondering if they're taking too long, feeling self-conscious about their body, this position removes many of those barriers. The body can relax, and a relaxed body can orgasm far more readily than a tense one. Reason 3, intimacy and emotional connection. Research from the Kinsey Institute has shown that emotional intimacy and feelings of safety with a partner are strongly correlated with female orgasm. This is less true for male orgasm. Men can generally reach orgasm in a wider range of emotional states. For women, the emotional context of the sexual encounter matters enormously to the neurological pathway of orgasm. The lateral position is, of all positions, the one that most promotes emotional connection. You can look at each other. You can speak. You can feel the warmth of your partner's entire body against yours. Kissing is natural in this position. Touch is full and reciprocal. All of that emotional input feeds into the neurological cascade that leads to orgasm. It is not soft or unscientific. It is literally part of the physiological mechanism. Reason 4, sustainability and deep orgasms. Because the position is low energy and the movement is gentle, this position can be sustained for long periods without fatigue. And sustained, gradual arousal buildup is one of the most reliable pathways to what researchers call a deep or full-body orgasm. The kind that involves not just pelvic muscle contractions, but waves of sensation through the entire body. This happens because extended, moderate stimulation allows arousal to build to very high levels before release, rather than a quick spike and drop. The lateral position is almost uniquely suited to this kind of slow arousal build. Version 1, face-to-face. Both partners lie on their sides, facing each other. The receiving partner lifts their top leg slightly, allowing penetration from the front. The penetrating partner's leg is between or beneath the partner's legs. Movement is a gentle forward-back rock of both pelvises simultaneously. Version 2, spooning. The receiving partner lies with their back against the penetrating partner's chest. Classic spooning position. Penetration occurs from behind. The top leg of the receiving partner can be draped over the partner's hip for access. In this version, the penetrating partner's hands are completely free to provide clitoral stimulation simultaneously. The spooning version is particularly powerful for orgasm because you have rear entry style anterior wall pressure from the angled approach, combined with full body contact and emotional warmth combined with easy access for simultaneous clitoral stimulation by either partner. My clinical recommendation: if you have never experienced a full orgasm during partnered sex, this is the position I would suggest you start with. The combination of anatomical alignment, emotional safety, and sustained stimulation creates the conditions that the research, and my clinical experience, most consistently associates with breakthrough orgasmic experiences. Before I let you go, I want to talk about one more thing, because I'd be doing you a disservice if I pretended that positions alone are the complete answer. They are powerful, they are evidence-based, they matter enormously, but the research is also crystal clear on this. The single most powerful predictor of female orgasm is not position. It is mental and emotional state. Specifically, there are 3 mental patterns that prevent orgasm more reliably than any physical factor. Pattern 1. Spectatoring. This is the term psychologist Dr. William Masters used for the habit of mentally watching yourself during sex, monitoring your own responses, your own body, whether you look okay, whether you're taking too long. When you're in spectator mode, you are not in your body, you are in your head. An orgasm lives in the body. The antidote to spectatoring is sensory focus. Bring your attention to what you feel, not what you think. Focus on the physical sensations: warmth, pressure, movement, breathing. Every time your mind wanders to a thought, gently return it to a sensation. This is a practice. It gets easier. Pattern 2. Orgasm as goal. When you make orgasm the goal of sex, every moment without orgasm becomes a small failure. That pressure, subtle as it is, creates exactly the psychological tension that prevents orgasm from happening. Research shows that women who approach sex with a pleasure-focused rather than outcome-focused mindset report significantly higher rates of orgasm. Ironically, the less desperately you pursue the orgasm, the more readily it arrives. Pattern 3. Unvoiced needs. If you know what you need to reach orgasm, a specific kind of touch, a specific position, more time, a particular kind of connection beforehand, and you are not communicating that to your partner, you are working against yourself. Your partner cannot read your mind, and they genuinely, sincerely want to give you what you need. Tell them, not as a criticism, not apologetically, as information, as a gift to both of you. So let's bring this all home. Today we covered 4 science-backed positions proven by urological and sexual health research to maximize the likelihood of female orgasm. Position 1. Modified missionary with the coital alignment technique for sustained external clitoral friction. Position 2. Woman on top with a forward grind for complete control over angle and clitoral contact. Position 3. Rear entry with anterior wall focus for internal clitoral complex stimulation through the G-spot region. Position 4. The lateral scissors for full body intimacy, sustained arousal build, and natural clitoral contact in the most psychologically safe configuration. And we talked about the mental dimensions that no position can replace: being present, releasing the goal, and using your voice. Here's what I want you to take away from today more than anything else. Your body is not difficult. Your body is not broken. Your body is extraordinarily well designed for pleasure. It just needs the right information, the right approach, and the right conditions. You deserve that. Your pleasure is not an afterthought. It is not a bonus. It is as legitimate and as important as your partner's pleasure. And today, I hope I've given you the knowledge and the confidence to act on that. If this video helped you, if it gave you even one thing you didn't have before, please give it a like. That small action helps this information reach the women who need it. Subscribe if you haven't already. I post every week on sexual health, intimacy, relationship science, and everything in between that your doctor doesn't have time to tell you. And I want to hear from you. Drop a comment below. You can be anonymous. You can use a fake name. I don't care. Tell me, which of these positions are you most curious to try? Or if you've already tried any of these, what was your experience? This community learns from each other, and your comment might be exactly what someone else needs to read today. I have new videos coming up on how to have your first orgasm, the role of testosterone in female sexual desire, and why some women experience pain during sex and what actually helps. So stay tuned for all of that. Until next time, take care of yourself, advocate for your own pleasure, and remember, knowing your own body is not vanity, it is health. I'm Dr. Lila Romano. I'll see you in the next one.